Hello, live start, sir.
Shall I start now?
Yes, sir, yes, sir.
So good morning, everyone. I am Dr. Sudeep, Pediatric Cardiology Consultant, King's Hospital. Now, today we discuss very important aspect of pediatric cardiology, that is history taking and when to suspect that. So, for that in pediatric cardiology, you can understand that 10 commandments will ask any pediatric cardiac patient antenatal history or family history, what is important, what is the mode of presentation as per the history. And after that, once you come, you go to the examination, then check the saturation. Then you have to decide whether the increased flow situation or decreased flow situation. Then take help of small things like plethysmography, your pulse oximetry, chest X-ray, ECG, and then again your amalgamation of everything. And then you have to take the help of echo, CT, MRI, angiogram, whatever is required. For any pediatric patient, suppose any patient comes to you, so this is a very time tested criteria, NADAS criteria, whether that is there or not in any patient, then you can decide that that patient has got the heart disease or not. So anyone having cyanosis or failure features, what are the features of failure and history, tachypnea, tachycardia, and then once you see the examination, any cardiomegaly or the hepatomegaly, the two tachy, two megaly is a feature of CCF. Or once you examine, you will get the pansystolic murmur with thrill or greater than that, or diastolic murmur. So when these are there, that is a major criteria. Apart from that, any abnormal BP like upper limb, lower limb difference is there, abnormal P2 sound is there, PSM less than 3.6, abnormal XCC. Why they come into the minor category? Because they are all subjective and they know exact. Sometimes it change with the subject variation. So now we'll go with the history. Now the today topic is how to take the history. So history is very important. If you see there, these are some example of history snippets where you can tell with this history you can able to tell what is a sudden death in the family. Suppose somebody give history, you can take there is a channelopathies, Brugada, long QT, arrhythmia, or HOCM. That is very important here. Sudden cardiac death. Somebody had syncope, so mainly it's a vasovagal, that is neurogenic syncope. Other cardiac causes of the syncope are only 5%, but they are mostly severe AS, PS, or Eisenmenger syndrome. If suppose mother has got no vaccination rubella and you find out the child having continuous 1 month, then you have to rule out that there is a rubella in the mother and that is causing rubella antibody, that is causing rubella syndrome in a child. Lithium intake, any antidepressant on the mother, then abstinence and obli. Any diabetic mother in pregnancy, that is called the HOCM in the baby. SLE in the mother, so that is causing the heart block in a baby. Then if you get the anti-epileptic, the mother is on anti-epileptic, that is causing the more chance of VSD and the neural tube defect. In the same way, if the mother is not taking folate properly, that is again the risk of congenital heart disease will be more. So this is in general. Once you started, the other clues where specific clues are there. But apart from that, once you see the any child, suppose some child come at the various age, so there are a specific criteria when the child will present at the specific date. Like in the first week of life, if the child presented with CCF, the specific are AV malformation, coarctation, complex congenital heart disease. Okay, so these are the things. Or if it comes later, then there is other criteria. So one, the time frame is also important when the child presented to you and when the child is whether it is CCF or cyanosis. So with that history, we'll tell you we'll go from the birth. So birth, there are various things are there when the child presents with cyanosis exactly at birth. The cyanosis exactly at birth have got three or four causes. Either it's a cardiac causes, respiratory causes, CNS cause, or hemoglobin cause. So respiratory is a respiratory distress or any other CDH or that all is a secondary auto rule out. Second is a brain cause. Then when the mother has got some injection or the baby is totally depressed and asphyxiated, that also will cause cyanosis. Then third is self methemoglobinemia also may present sometime congenital from that. Now if you come to the cardiac cause, so cyanosis at birth. is a very important history. Whenever any child had cyanotic at birth, there are two causes. Either duct-dependent pulmonary circulation, where the flow to the lungs are so less, it depends on the PDA, and when the PDA started closing by 2 to 3 days, 2 to 3 days, no, 2 to 3 days, then they started having cyanosis. Okay, and then second, the duct dependent left side condition. Although they present mass as a failure in the pallor, but they sometimes perceived as a cyanosis. So, like hypoplastic left heart or severe coarctation, they can also present like a cyanosis. So, cyanosis at birth is a very specific symptom. If you understand that in the history or in your presentation, you can able to take clue down the diagnosis in them. So, first, any complex heart disease is the most common. TJ is the most common cyanotic heart disease in neonate or at birth. Second is complex like tricuspid atresia, single ventricle, or sometimes without duct dependent like tricuspid or TAPVC, or most common is TAPVC, then single ventricle. So these are the causes which were, and if you go to the duct dependent pulmonary circulation like VSD pulmonary atresia, severe top where the valve is already atretic, or pulmonary atresia intact septum, or abstinence, severe abstinence at birth. So these are the causes which can present as a cyanosis at birth. So once you know these things, so you can able to tell these things. Okay. Now the second is systemic perfusion delayed. What is the systemic perfusion delayed? I already told, because the duct dependent circulation is on the right side, but when there is a flow delay at the left side, okay, so that is the cause for the decreased systemic perfusion. That also can present as a cyanosis. So like that interrupted or critical aortic stenosis, severe coarctation, they call the decreased perfusion to the left side, and that is causing the severe acidosis and the pallor. Okay, so now the third is tachypnea. Sometimes premature baby or sometimes term baby tachypnea can present as a PDA in a preterm is presenting as a failure as a before as compared to term, or when there is an obstructive lesion like tricuspid, no TAPVC or the severe truncus, they can present as an early presentation. So if you see in any cardiac, you see there are three presentations. One is cyanosis, second is systemic perfusion delayed, which can present as a failure or lower limb pulses poor, or third is tachypnea, increased respiratory distress. So if you see out of these duct dependent two lesions, pulmonary lesion present as cyanosis, tachypnea, and acidosis, while systemic present pallor, acidosis, shock, and renal failure. The lesions which are there in the pulmonary lesion are pulmonary atresia, VSD, critical PS, severe top. What here in that systemic is HLH, hypoplastic left heart, critical AS, interrupted aortic arch, or the severe coarctation. Okay. Apart from that, some neonate present only with the distress, without anything, no cyanosis and no acidosis, but they are the PDA or VSD. Sometimes they can present in preterm early. Why? I'll explain. Or the admixture lesion where they all are mixing at one place and causing the problem. The truncus, TAPVC, and the TGA. Okay, so these are the things. So now there is a very common question in the history, or when you why usually preterm present early as compared to term. So what happened? There is a three steps of PVRI decrease. So suppose PVRI, because the lungs are totally collapsed in the fetal life, as soon as they come out, once the baby takes first breath, the lungs will get expanded. So your lungs pressure PVRI, pulmovasorectal, this will come, PVR will come down, resistance, pulmonary vascular resistance will come down by 50%. So anything which halt this process, like your asphyxia or your chest deformity, will not allow this to PVR will persist and the pH will persist. That is the cause why the asphyxia is having the pH. Second is, after this, there is a smooth muscle is there across the pulmonary arteries, which will get remodeled. It was a thick in the fetal age and now it become thin. So one did this is known as the remodeling of the smooth muscles. If this is happened, usually it happened by 4 to 6 weeks. That's why all term baby, the flow to the lungs increase by 4 to 6 weeks in presence of large shunt. That's why all VSD, large PDA, they all present at the 4 to 6 weeks of with the drop of PVRI by smooth muscle remodeling. In premature, this smooth muscle is not at all. So as soon as they delivered, there is an increased flow. That's why the premature baby in premature baby PDA and VSD can present as early as 1 week, 10 days also. That's why the reason, because there is no smooth muscle remodeling. So these are the things. So we can tell cyanosis, we have explained, and what are the three cardinal presentation, why this presented early. Then third is there. The one there is a tachypnea. Or sometimes what happens, the cyanosis may be stuttering. There will be cyanosis beginning, and then there will be no cyanosis. And then again in the later life, there will be cyanosis. That is a typical of the Epstein's anomaly, that is known as stuttering cyanosis. Third thing is when the cyanosis is delayed, it's not present in the newborn, but it present up to 3 to 6 months. Why it happened? That is a typical of VSD PS, where there is a VSD and there is a PS, and there is known as the top physiology. So whenever this top physiology is there, so what happened? The top physiology, why the cyanosis is late? There are 3 or 4 postulates reasons were given. Like first, there is an increased obstruction in severity over the period. Second thing, when the child becomes grow up, then it becomes more active. For the same amount of obstruction, he needs more blood to go into the lung, and that is not happening with the increasing severity. That is causing the cyanosis. Third, the hemoglobin F, which has got the high affinity in the initial 1 or 2 months, will change to hemoglobin A, so they can present, so they go more affinity. So in spite of severe obstruction, they may not present with the severe cyanosis in the initial days. And fourth, sometimes PDA and collateral can be seen in the PDA can be seen in 1 to 2 months. So if it's closed by 1 to 2 months, then they develop as a cyanosis. So that is a typical, why the typical TOF, where the VSD and the pulmonary stenosis they can present late. So this is the one aspect of cyanosis. Then failure. Now I told you, now the 3 lesions, if we tell, now we'll go with the individual lesion, how they presented specifically. One is cyanotic CHD, second is acyanotic CHD, third is obstructive lesions. So if we get the cyanotic CHD, I told you the early cyanosis at birth, the tricuspid TJ is the most common, tricuspid atresia is the second most common, third is single ventricle, and apart from that, there is a TAPVC or the TGA. Okay, these can present as a cyanotic at birth. If the stuttering cyanosis at birth, which improve and later again come Epstein's anomaly. Little delayed cyanosis, that will be typical of VSD, PS physiology, top physiology, in which there is a gamut of lesion like DORBPS, top typical PS, tricuspid atria, which can present early or sometimes may late, but mostly present early, or CCTJ, VSD, PS, or single ventricle PS. So these are the one gamut of cyanotic. Once you come to the second lesion, like left to right increased flow. So there are 4 or 5 symptoms are there. First, they can present after 4 to 6 weeks mostly, except in preterm. If we consider term as a specific term, it will present after 4 to 6 weeks of age. First. Second, they have poor weight gain, they have recurrent respiratory infection, they have increased sweating, poor feeding. So these are the symptoms which is suggestive of CCF, increased flow to the lungs. So what are the reasons? That is the specific question they ask in any exam or anywhere, like your DM, like your DNB or your MD or your MBBS. Why there is an increase? What is the history of the increased flow situation? First is a poor weight gain. Why there is a poor weight gain? Because with the CCF, the all energy expend, there is a more catabolic state. So that's why there is a poor weight gain. Second thing, and in the CCA there will be gut edema, so there's the absorption of the nutrient also less. So the reason for poor weight gain is that you call it as cardiac cachexia. This cachexia is because of the cardiac lesion, so we call it as cardiac cachexia, that is typical of increased flow to the lung, left to right shunt lesion. Second, why there is a feeding problem? Feeding problem means suck rest suck cycle. So what is that? In neonate, or in infant, the main activity they are doing is the feeding. It's a suggestive of easy fatigability of low cardiac output. What happens when in the CCF they try to suck the breast or feeding, they'll get tired and then again they will take rest. So that is known as rest, and then again they will suck the suck rest suck cycle. So in general, any kid, when even after feeding he is getting hungry, and if it's taking more than 30 minutes in taking the feed, so that is suggestive of the poor feeding. And during feeding, if it find out the sweating, increased precordial pulsation, or the tachypnea, that is suggestive of the poor feeding or respiratory. Third is respiratory distress. So I already explained you the between 4 to 6 weeks lung flow will increase, but why there is a recurrent pneumonia in the large left to right shunt? So what happened in large left to right shunt in a bronchopulmonary segment? If you consider the pulmonary artery, bronchus, they are in the one plane, while the bronchial artery is into the bronchopulmonary segment plane, in between two bronchopulmonary segments. So once there is an increased flow to the lung, so the pulmonary artery will dilate, and the next bronchus, the bronchus which is present next in the bronchopulmonary segment, will get compressed. Because of that compression, there is the microatelectasis, and that is causing that is nidus or infection and causing the recurrent artery. That is the first. Second, because of the ciliary motility abnormality second, because of the immunodeficiency associated with these lesions third, and because they are poor in feeding, so their immunity is also low. So because of all these lesions, there is more chance of recurrent RTI. If the large left to right side like large VSD, PDA, the symptoms are poor weight gain. I told you why. Poor feeding, recurrent RTI, and the pneumonia. And the first, increase autonomic activity, because to CCF countering the body will form, try to do increase autonomic. There will be excessive sweating while feeding, or there will, if the mother touched the precordium, there will be hyperdynamicity of the precordium. So cyanotic lesion is a cyanotic, either early cyanotic or late cyanotic. There will be tachypnea, and then second is the large left to right shunt, which present mostly by 4 to 6 weeks in the large shunt. But and these are the symptoms. And the third reason is obstructive. Obstructive lesions, they are mostly asymptomatic for long time until unless the obstruction like aortic stenosis. If the aortic stenosis also there, the blood will go, but until it becomes so much significant, it will cause the LVH or LV dysfunction. It will not usually be symptomatic. But once there is severe aortic stenosis, they can present as a chest pain in the adult in the bigger group, or in any age group, they can present with the severe LV dysfunction, or they can present as a tachypnea. Or once it's there, they can present as a syncope also. In the same way, pulmonary stenosis, they can present as a cyanosis, they can present as a chest pain, they can present as a syncope. And once the coarctation is there, once there's a neonatal coarctation, it has got the bimodal presentation. Either it present early with severe symptoms of CCF, or it can present late in an adult age group like a accidental hypertension. We saw so many adult where they miss the coarctation beginning because nobody touched the lower limb pulses. So you have to check lower limb, upper limb pulses, because coarctation can present any hypertension in a young or even in adult. You have to check the lower limb pulses to rule out coarctation. So there are three symptoms. Now, if we do the cyanosis, and this is the beginning, but as the patient grow, it's very specific history. They will give the squatting episodes or the tachypnea history. Okay, so there are two difference between tachypnea of the cyanotic top physiology and the tachypnea of the increased flow. Tachypnea of the top physiology, there will be only rate will increase, but there is no intercostal retraction. That will parenchyma is not involved because this is the acidotic breathing. And large left to right shunt, when there is a cyanosis or there is a tachypnea, that will be all intercostal retrieval lungs parenchyma and involved. So history of squatting is a specific history which can be present, which can lead to your symptoms, or you can narrow down to the VSD PS top physiology. What happened? The squatting, why it's squatting happened, or when there is a spell history. Spell is present usually in the 1 year. The postulated theory is there when the child start crying or when the child start feeding or any activity, your lung flow should increase. But that lung flow is not increased because there is a pulmonary obstruction. The more cyanotic flow will go to the systemic side through VSD, and that will cause the lactic acidosis and the poor perfusion, and that will cause the tachypnea. And with that tachypnea, if continues, that will lead to the seizures, or that means bradycardia. So what happened? The typical history of spells are like that. Any inciting event like crying or activity, child will take the deep breath, and then there will be deepening of the cyanosis. And when if it's unattended, then it will lead to bradycardia or death. The typical history of spell. One, sorry. Second thing, once the squatting, once what happened, this is the this spell is because of the immature nervous system, because the nervous system is unable to handle the autonomic inactivity. So what happened when the child grows beyond 1 year or 2 years? First, whenever there is activity, he will understand when he will get the symptom, he will not go beyond that. So that's why he will understood. They will know how when to stop. So that's why the spells are less common. And more common reason, the brain and the brainstem become mature by after 1 year of age. So that's why they are unable to have this. Usually no spells after 1 year. But what happened when the child started walking and they started feeling like that symptom, he will squat. So with the squat, what happened? The femoral artery vessels will constrict. So because of that, the systemic vascular resistance is increased. So that more flow will go towards the lung side. So that is the mechanism of how squatting helps. Okay. And second thing is squatting also localized blood with the, because main blood comes on the lower limb, with the acidotic blood stay in the lung, in the leg itself, so that less acidotic blood will go towards the heart, and then it will cause the decreased acidosis. So that's how the squatting happens. So I told you two things: the cyanosis early, later cyanosis in presence of cyanotic spell or sweating or without that. Okay. So for that, two things you have to do. Any child cyanotic, they may not be evident cyanotic by just looking after. So there is known as cyanotic point. When the cyanosis will be evident, the cyanosis will be evident on naked eye mainly when the saturation is less than 85%. So you have to do the pulse oximeter, and it depends on the hemoglobin level. If the hemoglobin is less, even in 85%, you may not able to see. Or when in polycythemia, even 90-92% you can able to see the sinuses. So first you have to rule out. Put the pulse oximeter in all patients, you will come to know if there is a cyanotic cyanosis there or not. Less than 92% definitely cyanotic, or pulse oximeter on naked eye 85% is the cyanotic. So once you detect the cyanosis, once you rule out all those X-ray, ECG or clinical exam, you are unable to rule out other causes also. Like methemoglobinemia is very often missed. So when the sinuses are unable to get it from anywhere, check the methylglobin level. That is one of the cause for sinuses. Another now we saw the portosystemic shunt. Sometimes liver to systemic, there is a communication which cause pulmonary AVM, and pulmonary AVM portosystemic shunt also is the one of the cause for sinuses. So the other rare cause of the sinuses, when you not find out any cause in the heart, you have to look after for that. The other cyanotic. Second, I told you increase left to right shunt. So this happens. Apart from that, there are so many diseases where there is asymptomatic. So like ASD, they will remain asymptomatic left to right side for 2 to 4 years. The most common mode of presentation of ASD is accidental when they found out the murmur. In the same way, when the small VSD, small PDA, large, that can be got undetected for long time. In the same way, when the moderate AS, moderate PS, or the mild coarctation, when they're not symptomatic, they will not see. But once they become symptomatic or become severe, then only we'll able to detect. So asymptomatic is not the problem. That's why you have to take care. You have to take help from everything, your X-ray, your history. Now, one of the important point in history, who is giving the history? Because if somebody they will tell hole in the heart. You should not get confused. Hole in the heart means hole, because for the layman everything is hole in the heart. Even the complex disease they call it as hole in the heart. So never go with that. Do your proper history examination and then you come to the conclusion. Second thing, the very important, from which place they belong to. Like for example, in Telangana, Nalgonda, Suryapet area is a very known for beriberi. So whenever any child comes with CCF, even severe PH cyanosis, you have to rule out beriberi in such case. In the same way, if you go to the Kerala, so they have some cardiomyopathy very common in the coastal belt. Some places filariasis is common. So you have to go with the localized pattern also. Like if you go to the MP and that area, you got the infantile tremor syndrome with cardiac involvement with the multivitamin deficiency. So these are very common as per. If you go to the hilly area, the PDA is the most common lesion. So if you know the geography also, that will be important. Who is the informant? What to do? And sometimes the patient will tell you asymptomatic, but asymptomatic patient also may have severe disease like CCTG. I told severe aortic stenosis, severe pulmonary stenosis. When they don't have a symptom, you may not able to detect. So don't go only with the asymptomatic status. Asymptomatic status may have some disease. Even some diseases may go up to the adult age, like ASD, CCTG, aortic stenosis, bicuspid aortic valve, PS, PDA, moderate VSD. Even they go. Sometimes when these large defects were not detected and treated at time, they will go into Eisenmenger syndrome. The Eisenmenger syndrome is a condition where the large defect, like mostly VSD, ASD, PDF, is got untreated. The lungs pressure becomes so high that shunt will become reversal. So then it becomes unoperable. So we have to think of it that present as a cyanotic heart disease or syncope or dyspnea or hemoptysis. So these are the things. Now, few of the important things where edema. Edema is very rare in the pediatric age group until you get edema from the abdominal edema, and then go to the pericarditis specific of right heart failure, right-sided cardiomyopathy, constrictive pericarditis, restrictive cardiomyopathy. They can present as an abdominal edema and then circulated over there. Okay, syncope. I already told ASPS, Eisenmenger can present as a syncope. So these things, hemoptysis is a very here in cyanotic heart disease, tuberculosis is very common. So in any hemoptysis, first think of tuberculosis. Then there is a bronchial artery bleeding, which is more commonly seen in Eisenmenger syndrome, which is more seen in the TOF patient. So you have to rule, you have to take, and in adult or little upper like rheumatic heart disease present in the mitral stenosis. Okay, so these are the history. Now the fourth history is the rheumatic heart disease history. Now what are the rheumatic heart disease history? joint pain, fever, you have to do the Jones criteria. Then, but you may not able to find erythema node or some nodules in every patient. But once you have to suspect in any case with the tachypnea and the murmur, which is most common wall involved is mitral valve because it got the maximum pressure with whom it work across all wall and to the heart. And then it has got the large area so that the mitral valve is getting most commonly affected in rheumatic heart disease. In more than 5 years to 15 years, it mostly present as a severe MR. But in India, it can present as an early MS also, which is known as juvenile MS, which is the entity in the endemic zone like India. Even the 15-year-old can present with the severe MS. So you have to think of the rheumatic heart disease because in rheumatic heart disease, 33% patient without any history, they can present directly with the cardiac lesion. So the onus is on the pediatrician as well as the cardiologist to think over the all those history points. So antenatal, we told ki whenever the mother has got there, then one of the thing when any family member affected, so any family member affected, like any sibling affected, the chances normally 1% is the chance for any newborn baby to have heart disease. But if the one family member affected, one sibling, then it becomes 4 to 5. And some reason has got the more higher propensity if the one of the sibling got affected, like hypoplastic left heart. If one affected, second has got the 9 to 10% of the chances. But in general, the chances will be 4 to 5% if any father affected, mother affected, or any sibling affected. So to take the previous sibling history also. Sudden death in a previous sibling also you have to do the long QT, HOCM, these are the possibilities. Sometimes coronary artery disease, where the coronary artery is going abnormally and compressing, that is also cause the sudden death in some patients. So when the sudden death, syncope, this you have to do. And second thing, vaccination in the mother is very important because rubella is very common with in absence of vaccination. So if you see from the sibling history, and you have to ask any sibling underwent any surgery for the cardiac surgery. Recently, we saw a family of 3 people having the PDA. All 3 siblings have PDA. So once the PDA, the sibling, the second time sibling has got the high propensity of the PDA patency. So you have to see like that. Only 99% it's a multifactorial. Only in few cases it's a genetically associated, like heterotaxy, which is a complex heart disease, which is genetically associated, or long QT, which is genetically associated. HOCM genetically associated. Rest all are multifactorial in congenital heart disease. If you go from the sibling history, antenatal history, and then the neonatal history and the next history. So these are the in general, if you see. So now one last thing we'll tell. What is the cause for cyanosis at birth? So if you see CCF at birth, if you see the cyanosis as per age, the most common heart disease I told DTG, hypoplastic left heart, and severe TOF, not typical TOF, routine TOF, severe TOF like atresia or hypoplastic right heart. One the 7 to 13, the HLHS, DTGA. So other less common are tricuspid atresia, single ventricle. When there is a CCF features, the large AV fistula, severe PR, premature having the PDA, severe aortic stenosis, this has got the hydrops fetalis in the first day of life. First week, the most common is critical AS, PS, and the coarctation. While first month is coarctation with large PDA, large VSD, already told reason PDA, AV septal defect. And later it can present with, and the rhythm abnormality and cardiomyopathy can present at any time. And the last thing, what is the cause of the murmur on the day one? So day one murmur, there are 2 types of day one murmur. Okay, so there is a physiological, if you see, tricuspid TR, peripheral PS and PDA, but the pathological, any semilunar wall syndrome like ASPS can produce murmur on day one and the significant AV wall regurgitation. So if you see, these are the, in general, the examination, the history point. Now the second thing is examination as well as the X-ray history that will go into the next session. But this is in general the history. What is the cause for sweating? What is the cause for spell? This is the very important question. Why there is a recurrent RTI and why there is an increased feeding difficulty in layers left to right side, why they are present at 4 to 6, why preterm presented early, how the stuttering cyanosis, why the cyanosis will be late, what is the radiofemoral delay. These all are the significant important points on the history that we can have to consider. And once you consider that history, geography, who is elected, what is the old thing done, when the surgery was done, what the doctor suggested. If somebody told there is a hole, what the doctor suggested to do for surgery, so then you will understood there is a significant problem. That's why the doctor suggested for surgery in the past. And when the patient not underwent any surgery, then it developed into Eisenmenger, hemoptysis, edema, syncope, chest pain. That all we have to consider. So I think that is enough for the history point. Later we can, in the next session, I think we can go ahead with the examination as well as the X-ray, ECG, echo, and the next one. Thanks a lot.